Good afternoon and welcome. I'm Ezekiel Emanuel, the Vice Provost for Global Initiatives, a physician, and I worked in the global health space for many years in the administration. It's a pleasure to have all of you here for a conversation on global health at this very, very important moment in the global health trajectory. The 21st century has been both the golden age of global health, but also a most frustrating age recently. In the early 2000s, we had, of course, the founding of the Gates Foundation, of other major initiatives, including PEPFAR, the Global Fund, and we had double-digit growth in global health funding for a decade. And then the financial crisis hit. We had a plateau that extended all the way through COVID, and then another dramatic increase in global health funding during COVID because of COVID. One of the things all of that period of time has highlighted to us is how much can be accomplished, but also how much of it is not just narrowly focused on health and delivering healthcare services. Tens of millions, hundreds of millions of lives have been changed by the 21st century focus on global health. And again, it wasn't just about medicine. One of the things we learned is that a key principle behind the expansion of global health and to make it successful was to ensure that we were focused on the most disadvantaged people in the community by focusing on LGBTQ communities, sex workers, those with limited access to care, the poor, the rural people. You had the biggest impact on public health measures, and it benefited everyone in the community. This was shown through HIV/AIDS. It was shown through malaria and other items. Unfortunately, the plateaus in funding have created a challenge for everyone. Global funding for global health reached, I think, a maximum of $39 billion. And in the last few years, led by President Trump, there has been a decrease for the first time in the 21st century on funding for global health by the four biggest funders, the United States, the UK, France, and Germany. We have tremendous pressure, therefore, to figure out what to do, how to think about global health financing, the priorities that we should have, and the multilateral cooperation and how that should be effectuated. So the big question before us is, what comes next, and what should our priorities be? It's with great pleasure, therefore, that we are fortunate to be joined by Winnie Byanyima, right? She is the executive director of UNAIDS, the Undersecretary General at the United Nations. She has an illustrious career that goes from Oxfam to the Ugandan Parliament, and incredible focus on global health. She is going to come, and I'm going to introduce Harvey Rubin from our Center for HIV/AIDS, who is a fantastic professor of medicine and relentless and tireless worker in the space of global health and HIV. So with that, Harvey.
Hello, good morning. It's a great honor to be here today, and thank you, Zeke, for that introduction. My name is Winnie Byanyima, as you've heard, Executive Director of UNAIDS, the United Nations Joint Program on HIV/AIDS. At first glance, I may seem an unlikely choice for this role. I'm not a doctor. I'm not an epidemiologist. I came to this position from Oxfam, an international NGO. Before that, I was a revolutionary in Uganda's what we call the Bush War, fighting for democracy. I've led women's movements, social justice movements across Africa and globally. At heart, I'm an activist, someone shaped by a lifelong struggle for human rights, for social justice and equality. And that's precisely why I'm here. Because ending AIDS has never been only a medical challenge. It's a battle shaped and often determined by inequality. I was asked to lead UNAIDS because HIV is not just a virus. It is a mirror of the world's economic and social inequalities. Today, I want to share two things. One, how social justice has driven one of the most successful public health responses in history. And secondly, why that model is now under strain. We can think together about solutions. It's been over 40 years since HIV was first identified. There's still no vaccine and no cure. And yet, AIDS-related deaths have fallen by about 70%, and new infections have fallen by 60% since their peaks. How was this possible? Of course, through science, through powerful tools for prevention, for testing and treatment. Today, people living with HIV who are on treatment can suppress the virus to undetectable levels and live long, healthy lives without transmitting it. But if that were the whole story, the epidemic would be over. Instead, at the last count, that's 2024, there were 1.3 million new infections globally, and 630,000 people died of AIDS-related illnesses. Why? Because when the data is unpacked, when it is examined who is newly infected and who is dying, a clear pattern emerges. There. Oh. The burden falls overwhelmingly on the global south, particularly sub-Saharan Africa. And within countries, it falls on those pushed to the margins, adolescent girls and young women, LGBTQ people, sex workers, and people who use drugs. HIV at its core is about inequality. Inequality between countries, where global economic rules shape who can access medicines, technology, and financing, and inequality within countries, where social and economic status determines who is protected and who is left behind. Let me explain. I won't go into that graph. After more than a decade of devastation from AIDS, a breakthrough came in 1997 with the development of highly effective antiretroviral therapy. In high-income countries, infections and deaths quickly began to fall. You can see on that graph, you will see that between 1996 and 2003, high-income countries had ARVs, Africa didn't have them yet. You can see that deaths are still increasing, but once the treatment came to Africa, then the whole world, you see decreases in deaths and new infections. But in low and middle-income countries, access didn't follow, not immediately. For nearly a decade, millions were left without treatment. and an estimated 12 million people in Africa lost their lives. The divide was stark. Life-saving medicines existed, but they were not reaching those most in need. This was not an accident. It was the result of how the global system for medicines operates. New treatments were protected by strict intellectual property rules that granted companies monopoly control, even where public funding had contributed to their development. Prices were set around $10,000 per person per year, completely out of reach for countries facing millions of people living with HIV. Then, faced with this injustice, activists across Africa, Asia, and Latin America mobilized. They organized, they protested, they demanded action from their governments. They were joined by allies globally, including communities in the United States, particularly of gay men, and Europe, who had fought for access to treatment and refused to accept a world where access depended on geography or income. Under this pressure, governments in low and middle-income countries made use of flexibilities in global trade rules to import affordable generic medicines, particularly from India, despite the strong opposition from the pharma companies. This, combined with sustained activism, forced a shift. Companies began to license their technologies and prices fell dramatically. Overnight, from $10,000 to under $70 per person per year. This transformation was matched by political leadership and global solidarity. That's when the United States launched the PEPFAR program, launched by President Bush, the largest HIV program in history, the largest global health program. The Global Fund was established to pool resources and expand access. Communities were placed at the center of delivery. The results have been extraordinary. Today, 3/4 of people living with HIV are on treatment, 31.6 million people out of 41 million living with HIV. So whether you're in Philadelphia or in Pakalane in South Africa, you have access to life-saving medicine and you can be on the same cutting-edge treatment. This progress was not inevitable. It was achieved by challenging an injustice. Yet, the structural barrier, that barrier of intellectual property rights, was not fully dismantled. Intellectual property rules continue to limit access to newer medicines, particularly in middle-income countries that are often excluded from licensing agreements. I can tell you more about this because we're in a struggle with Gilead, an American company, over its protection, 100% effective protection, lenacapavir. So the lessons from HIV are not consistently applied to other health crises. And we saw this during COVID. We can talk more about that. That unfinished agenda remains. The second issue of inequality between countries. The global financial architecture is structurally skewed against developing countries because it was designed by neoliberalists in rich countries. It gives the richer countries disproportionate influence in institutions like the IMF and the World Bank, while setting rules that prioritize creditor interests over development needs. Developing countries often borrow in foreign currencies at higher interest rates, leaving them exposed to exchange rate shocks and rising global interest rates. As a result, many are trapped in cycles of debt. They take on new loans to service old ones. They divert public resources away from health, education, and needed infrastructure. This dependency is reinforced by conditionalities and limited access to fair restructuring of debt mechanisms, making it difficult to escape indebtedness and to invest in health, in education, and in other priorities. COVID exposed the deep inequalities in access to global finance. As lower income countries sought resources to procure vaccines and essential medical equipment to save lives during COVID, the IMF issued $650 billion in what are called special drawing rights, effectively creating new liquidity. But because these were allocated according to existing quota shares, over 60% went to the high-income countries, while low-income countries who needed it because they were indebted received just 3%, leaving those most in need with the least support. There were efforts to correct this imbalance because the creation of new liquidity was about helping those countries that needed to borrow to buy the vaccines. So there were efforts, including voluntary reallocation of these special drawing rights, but it all came too little, too late to alter the course of the crisis. There was another framework by the G20 called the Common Framework for Debt Relief to suspend the debt repayments, so that countries could buy life-saving vaccines. That too proved very slow and inadequate. In fact, only 4 countries accessed it, and they got it as COVID was ending. So the lender of last resort, the one that was supposed to cushion countries from economic shocks, the IMF could not respond, neither could the World Bank that was designed to end poverty. The result is that a structural injustice in the global finance architecture remains unchanged. If another global health emergency were to strike, and it will strike, there's still no effective mechanism to ensure timely and equitable access to financing for countries most in need. Come to domestic resources then. Developing countries, especially in Africa, lose billions of dollars each year to tax dodging enabled by global loopholes that allow multinational companies to shift profits from where they create the value to low and no tax jurisdictions, depriving governments of vital revenue for health, education, social protection, and other critical needs. The current global tax rules, largely shaped by the richer countries, prioritize where companies are headquartered rather than where economic activity actually takes place, systematically disadvantaging developing countries. I have some data for 2023. Sub-Saharan Africa received $61 billion in aid, foreign assistance, but it spent $85 billion in paying the interest on its debt. Received 61 as aid, but spent 85 to service debt, and lost an estimated $88 billion to illicit financial flows, mostly tax evasion. So even before the aid cuts that happened in the last 2 years, for every $8 that flowed into Africa, there were $2.8 draining out, a total net transfer to the richer countries. Social justice movements have long campaigned for reforms to increase transparency, to tax profits where value is created, to establish a fair global minimum tax, and to close the tax loopholes. There are currently ongoing negotiations at the UN to establish a fair global tax framework, without which developing countries will never be able to raise enough domestic resources to fund health and other development priorities. So those are inequalities in the global system that deny developing countries the opportunity to meet the health needs of their people. But now let me turn to inequalities within countries. Social inequalities expressed through stigma, discrimination, criminalization, and the denial of human rights shape who is most exposed to HIV, who is least able to access prevention. You can see for HIV, those facing these structural barriers bear the greatest burden. Adolescent girls and young women account for 2 in every 3 new infections in sub-Saharan Africa. Every week, 3,300 young women and girls acquire HIV every week. You can also see here the prevalence rates. While global adult HIV prevalence is about 0.7%, it is around 10 times higher among gay men, transgender people, and people who inject drugs, and around 4 times higher among sex workers, and roughly double among people in prisons. These disparities are driven not only by stigma, but by laws and policies that institutionalize inequality. 64 countries today still criminalize same-sex relations. 14 criminalize transgender people, and many, more than 100 criminalize sex work, minor drug possession. They criminalize HIV non-disclosure, HIV exposure, or transmission. Evidence shows that gay men in African countries that criminalize them face HIV prevalence rates 5 times higher than in countries that do not, and up to 12 times higher where recent prosecutions have taken place. Globally, countries that criminalize key populations, we call these groups key populations, have mounted less effective HIV responses with lower rates of testing and treatment coverage. Progress against AIDS has been achieved where these inequalities have been challenged. When the pandemic began, most of the world criminalized same-sex relations, but it was through sustained advocacy, human rights movements led, and that led to significant legal reforms. In recent years, countries like India, Namibia, Barbados, Venezuela, across the world have been repealing these laws. These shifts have been critical in changing the trajectory of HIV. At UNAIDS, we work with communities, we support them to lead HIV responses, LGBT communities, young women in their groups, people who use drugs in their own associations, and so on. That is a picture of the NGO delegation that sits on our board. Evidence consistently shows that community-led programs are the most effective in reaching underserved populations. We, UNAIDS and the Global Fund, have embedded this principle in our governance, with communities represented alongside governments and multilateral agencies on our boards. They work hand in hand with governments at the country level, even in contexts where they face criminalization. Uganda has one of the harshest laws in the world on same-sex relations. That's where I come from. But in Uganda, I work with associations of gay people. They are not even legal in the law, but I work with them. We sit with the Minister of Health to design HIV programs. That is how the HIV movement has been able to succeed, by bringing the communities at the center of service delivery. This approach grounded in confronting inequality and advancing social justice, has helped to build a global HIV response that has saved nearly 27 million lives. And the opposite was also true. Without addressing stigma, criminalization, and the denial of human rights, these gains would not have been achieved. But today, this is my last part, these fundamentals, these principles are under threat. Actually, you call it the JIPA principle, greater involvement of people living with HIV. That principle where we have communities leading right from the ground level up to a level of global governance. Now, today, we have a far more contested geopolitical environment. The HIV response is confronted with a new reality. Across many regions, including parts of Africa, we see cultural and political battles that are pushing back against human rights, particularly the rights of women and girls, sexual and reproductive health and rights, and the rights of key populations. A coordinated, well-funded attack on rights. And for the first time since UNAIDS began tracking these trends in human rights, we find that the number of countries criminalizing key populations has increased rather than declined for the first time. This is colliding with a sharp contraction in global solidarity, an attack on rights and a contraction of resources, global resources to support developing countries. Aid, longer cornerstone of the HIV response and the wider global health architecture, fell by 17% in last year, following a 9% decline the previous year, and we are expecting an almost 30% decline this year. At the same time, funding is increasingly tied to political conditions, putting at risk the rights-based approaches that have been central to progress. Later on, we can talk about the new policy of promoting human flourishing in international assistance. It's a new policy, 3 rules that are conditioning all American assistance to development assistance. These pressures are unfolding in a world already marked by overlapping crises. Conflict is displacing communities, disrupting services. Climate shocks are straining fragile systems, and the long shadow of COVID continues to affect economies and to weaken health systems. Together, these forces are exposing the limits of an already fragmented and overstretched global health architecture. And yet it's also a moment of possibility. Across Africa and other regions, there's growing determination to achieve greater health sovereignty. Countries are coming together to reduce dependency and to build more sustainable, resilient systems. There are initiatives such as the Accra Reset, the Lusaka Agenda, alongside ongoing reforms at the United Nations, efforts by the WHO, all pointing toward more coordinated, more country-led, and more resilient approaches. There's also increasing emphasis on sustainable health financing, including efforts to expand regional production of medicines and health technologies, reducing on external reliance on and strengthening local capacity. There are also emerging financing models, such as global public investment, an idea which I think its time has come, seeking to position health as a global public good, supported by all countries for the benefit of all. As these new directions take shape, one lesson from the HIV response must remain central. Progress is built on social justice. Human rights must be protected, not traded away. And communities must affected must continue to lead, to shape prevention, to deliver services, and to hold systems accountable. The future of the HIV response, because, hey, we have 9 million people out there living with HIV who are not yet on treatment, and we have 1 million and more newly infected every year. So there's still a journey. The future of the response and of global health more broadly will depend on whether these principles that have led success to where we are upheld in the face of the current headwinds. Thank you very much.
Thank you, Winnie. That was really, I may call you Winnie. That was really remarkable. And it reminds me of the famous old saying that it's a truly remarkable person who can keep two opposing ideas and still function. So your pessimism, but your optimism is really, really remarkable. So we need people like you for sure. I met Winnie several years ago at a 17 Rooms conference at the UN. That's what her beautiful little pin is here, little different colors of the 17 Sustainable Development Goals. We could put the next slide up, please. And the one, I rarely remember things I hear in seminars, but I remember one thing that Winnie said that really opened my eyes. And she said, if you're worried about HIV, then also worry about education of young women in schools. She made the point that if you keep young girls in school, the incidence, and she mentioned the rate of increase in young women in HIV, but she made the point that if you keep young girls in school, that rate goes way down. So the ability to connect the dots that Winnie's been able to do over the years is really quite remarkable. And I think it's important to say that in the context of where we are in these sustainable development goals. And I know that's something that she's been intimately involved in over the years. The Sustainable Development Goals are under review. 2030 is the review date. We're less than 5 years away. How are we doing? We're not doing particularly well. 18% of the Sustainable Development Goals, and you can see them up there on the slide, poverty, education, global health, energy access, and so on, clean water, food security. Only 18% are on track. 48% are making moderate gains. Another 18% are either way off track or actually showing regression. And so there's it's estimated of over trillions of dollars in a funding gap annually to reach these Sustainable Development Goals. So I was thrilled to be asked to moderate this so that I could really press the most knowledgeable person that I know who worries about these things. Winnie, how do we think about, in your optimism, how do we think about the funding gap? How do we think about the structure of your beautiful pin here, these 17 Sustainable Development Goals? Are there too many? Are there too few? Do we need to, and it's called 17 rooms, do we need to find doors between the rooms like you did with education and HIV? What's your sense of where we go now for the next 5 years as 2030 looms and we have a different color scheme for the Sustainable Development Goals? What do you think?
Well, thank you for that question and for the kind words. First, I think it's good that we are able to track our progress, even though we have done badly, but at least we measure, we know where we are. We know there's a big question of financing. Let me give you an example of something we are working on. We're working with some smart people, development financing people, and they are telling us they're estimating how much just the debt relief, how much resource could be released if there was comprehensive, timely debt restructuring, how much resource could be released and what it could achieve for those countries. Huge. And that's just one stream of funding, just to unlock that debt trap for many countries. So we need to solve the question of financing. There's the debt issue, there's the unlevel ground in the global financial architecture. There are ways we can make financing more accessible equitably for developing countries. We should, and then unlock domestic resources, close that framework, complete that framework to stop tax dodging, to have companies pay where they create their value in the developing countries. If we could unlock that financing question, these could be achieved, but it's not enough.
Yeah,
There's the issue of rights, as I've said. The rights issue, that what is at stake here, what we are counting as not achieved, is largely to do with denial of rights. That too, we have to push back against the pushback on human rights and get countries to respect, to protect and deliver on human rights for their people. I think those two areas, crisis, ending wars, that means reforming the Security Council so that we can have a body that actually can be effective in preventing and resolving conflicts. There are those structural questions that need to be addressed if we are to achieve the Sustainable Development Goals. And I am with those who think that maybe we don't want to have new goals, but like you said, find those fewer things that when you achieve, you solve others as well. You call them the doors. I agree with you on that.
That's great. I think linking social justice to global health is really, it sounds easy, but it has a historical ring to it that is so important. And I think in terms of what we do here at Penn, thinking about that as a sort of a theme of basic research is really important. And I must admit, I don't want to compare anybody to anybody, but Eleanor Roosevelt really was the person who said we need to have the Declaration of Human Rights when the whole UN was started. And if there's a reincarnation of Eleanor Roosevelt, I think she's sitting on the stage right here. We want to open the conversation. So Winnie is brave enough to answer lots of different questions. So please, we have microphones that can go around right here in the front row.
Yeah, but these are very clever people. I can't answer their questions.
Especially the students. Watch out for them, right?
Hi, thank you so much for being here. I was wondering particularly on the role of China in global health. So my question is, how would you compare the model that the United States has or had with USAID with respect to public health initiatives versus the model of BRICS and maybe particularly China that's framed as part of the South-South cooperation? So do you think one is more sustainable through time, more resilient, or perhaps more effective? And of course, their emphasis on social justice and disadvantaged individuals.
Oh, that question. That is, working for the United Nations and watching how different big powers have engaged on development, the more I look, the more I see similarity than difference. Yet, when the scholars are describing how the West engages in development cooperation and how China does it, you see so much difference in what they describe, but I continue to see a lot of similarity. I like China's model of South-South collaboration because it's, first of all, less paternalistic. It's about, let me share what I know. If it works for you, good. It has challenges of transparency. It's often government to government, but hey, look, even the Western model is less and less transparent. Right now, we are having memorandums of understanding on health financing by the United States, government to government. And suddenly people are finding that there are real serious issues with the agreements in terms of constitution, not being aligned with constitutions, not respecting financial rules, privacy of data, and all of that. So you see that China has its model of engagement. I like the South-South collaboration part, the sharing of technology, sharing of knowledge. I don't like the lack of transparency part. They are also more long-term, which is very good, whereas a lot of traditional domestic assistance is very project-based and short-term and undermines the possibility of achieving impact. It's sadly also the Chinese model of development sometimes very much locked in resource extraction that is not negotiated with those who are affected. So the impacts, the long-term impacts on ordinary people, it may achieve growth, but growth that's not inclusive and that's not respecting human rights. But that's also true of the other model. The other model tries to introduce conditionalities, but we've seen them abandon those conditionalities over time. The human rights conditions, they've abandoned them and they are seeking to adopt the Chinese model today. The Western donors are now saying, we want to trade, we want less conditions to aid, we want more aid for trade. So I'm seeing more convergence in the two models. What I would like to see is an end actually to the aid model being the main way of development cooperation. We need to change that. We need to move from a charity model to a solidarity model. We need to pay more together for global public goods and be taxed for them and gain from them according to need rather than a model based on aid. But I have to say that I see more and more converging of the two models, more convergence than divergence.
We have another question.
Hello, thank you so much for that conversation. It's been amazing. I'm actually going through Zoom questions. I'm supporting the online audience. So I have two questions. I'm wondering if you want to take them together or you'd like to do them separately. Okay. So let's just try. So the first one is actually an extension of the answer that you just had on aid. In your view, what are the most important policies that PEPFAR partner countries can take right now to mitigate the immediate service disruptions of recent aid cuts and plan for greater long-term sustainability of country HIV responses? So that's the first one. And the second one is, what is something individual public health practitioners in the US can do to support global efforts in ending the HIV pandemic? What is something we should not do? Repeat the second one. What is something individual public health practitioners in the US can do to support global efforts in ending the HIV epidemic? What is something we should not do?
The first one is about responding to the disruption, right? And you're asking about, yes. The disruption, I think the most important thing is that developing countries that were depending highly on aid for their HIV response were severely disrupted. Now, the solution is to move quickly to finding other ways of financing the HIV response, but it can never be the same again. So what you had before HIV response was a PEPFAR program that was very generous, that was designed for impact, for good results, that paid staff local staff very well in order to deliver good results. Now you have broken, fragile, poorly equipped, poorly staffed health system trying to absorb that very good machine created by PEPFAR. So I keep telling health workers on the ground that, let's get real. We had this gold standard of HIV program, but was sitting parallel to a health system that's broken. Now we have to come together. We have to find a way to bring what we had in this gold standard program and connect it to a weak system while protecting the core things that made it successful, the core things, the human rights, the communities at the center. How do we build them into a broken health system that is not human rights centered, that does not respect or work with communities? These are the challenges. But the model that was so expensive was always unsustainable, was never going to be taken forward by poor developing countries. So those are some of the mistakes we have to learn. We have data systems, for example, a country like, I will mention it, Tanzania. When USAID was closed, they switched off their computers and left. People were coming to clinics and somebody sitting there didn't even have their name, didn't know what kind of treatment they were on. Ordinary people coming to get their tablets, and there's nobody who knows what they should get. That's how bad it was. So this kind of heavy dependence on our foreign assistance and structures that are costly and unaffordable, we have to go away from that. So developing countries are now thinking and saying, well, let's start, but let's now be sure that what is there is affordable. But the key things that should be there that I fear we might lose and lose the gains are centering human rights, centering leadership of communities. These have to follow in an integrated system. What should you do here, health practitioners here and those at home? What should we not do? One, I think we should not cry over spilt milk. I think that there were many, many good development practitioners who were the army of USAID around the world doing great things. I was crying as I saw them lose their jobs. Let's not cry over that, but let's rethink how development cooperation can happen, not in a charity model, but more, as I say, a solidarity model. Let's rethink how development is financed together. I say that to the workers on the ground in Africa too. Some of them are locked in angry conversations with their governments. They see the governments are letting them know. I say, but be realistic. You can't expect them to take over something that was funded by the richest country in the world. Let's propose something simpler, easier, but that carries the gains. So that's what I would say. Don't cry.
There are two practitioners in the audience that I know quite well, and you can ask them. Just these two gentlemen here. But in terms of what practitioners should do, and I should also point out that Nick Kristof in the New York Times has been documenting the consequences of the closing of USAID, and it's in the hundreds of thousands of people that are dying because of that. So keep your eye on what Nick Kristof is writing about. I want to leave time for more questions, but so Ron or maybe you can just quickly answer, what should practitioners do?
Well, if I had, so first I want to say thank you for your words for this talk. I want to thank you for your advocacy over an extended period of time, and especially thank you for the work that UNAIDS has done. It's been extraordinary, so thank you. If I had the magic answer, I would be writing it myself in the New York Times. I think it's important for everyone at the grassroots level to communicate outwards to people locally, to help other Americans understand that this is human rights, but it also is America's security. And the goodwill that was generated through the PEPFAR program is extraordinary. And, you know, it may seem like a lot of money that was spent on PEPFAR, but it's a bargain compared to, shall we say, a war. So that'll be the limit of my
No,
comments.
that's great. And we'll have time after the meeting to discuss. And these two guys really are at the front lines. So use them. Robert, go ahead. You want to make a quick comment?
Sure. I want to echo Ron's appreciation of your comments. Harvey said something early that I think was very apt, and it was the knock-on effects of the education of girls to decrease the incidence of HIV in that population. Are there other low-hanging fruit areas that we should be focusing on that would be cross-cutting, that don't look on the surface to be related to the HIV/AIDS goals, but in fact should be where we are investing our efforts so that those knock-on effects lead to benefits in HIV/AIDS?
Especially in the area of human rights. I mean, if you decriminalize, so if you take away that offensive law in Uganda, suddenly you will see your new infections drop because gay men will come out of hiding and come and get what they need. We've seen that, that the respect for human rights, you don't need money, just repeal a law. And when you repeal a law, because laws also drive stigma, the society also shifts its thinking about the people who are criminalized. So these are immediate things that deliver results for HIV. But I mentioned, I was talking about keeping girls in school, but there are also some things that are controversial culturally, but if you do them, you make huge change, like sexual and reproductive health services for girls. Just training one of the teachers in a school how to deliver sexual education, just sexual education, the basics, what you need to be aware of your body as it's changing as a little girl, as a young girl. That also has huge, huge impacts. So we see that there are, and then when you put them in combination, you achieve even more impact. If you keep a girl in school, but also have a teacher who can give a little sex education, then your results are multiplied several times. If you also have that sexual education extended to all the kids, including boys, and they also know about their sexuality, again, even more results. So it's a combination of things that often then deliver a strong health outcome.
That's great. Was there another question on that side? Yeah, please. I think we have time for that question and one more after that. And
thank you. Thank you very much. I used to work for UN Women, so I came from the United Nations before.
Well, the Zoom people need to hear you. Right.
Hello, Zoom people. And I'm at Penn now doing my MBA because I want to try and understand the role of the private sector in fighting all of these battles. So as you think about the solidarity model, what role do you think the private sector has beyond just taxation?
That's a trick question, because I always say that I've never been optimistic about companies playing a role in development as corporate social responsibility, mobilizing them to respond from a perspective of they make a lot of money, they must give back. They must give back through taxation, we must tax them. We don't expect them to be saints. We expect them to do their duty to the state, to the people. So taxation for me is key, and we need to do more to tax the rich, to tax big companies and wealthy people, and those, because a lot of the money they have anyway is either inherited or achieved through their connections with government. So taxation to me is the key thing, progressive taxation, and closing the loopholes they have made for themselves to transfer their profits. I do not like that. Just yesterday, I made this tweet about a woman lawyer for Goldman Sachs who was associated with that abuser of girls and was now given her $25 million bonus and reluctantly let go. She'll be leaving in June. And I questioned, one, that companies can pay so much money to their leaders. What do they do that's in 24 hours of a day that other people don't do to build the economies and their societies? There's overpay. There's and then they put the money in philanthropy, and then they come and take over the power of elected governments. We sit in meetings with the foundations, I won't name them. They have a bigger voice than the governments themselves. They shape global health policies because they have brought, but the money they have made wasn't taxed. If it was properly taxed, they wouldn't have so much money. So I am ideological in that sense that I would like to see companies and wealthy people pay their fair share so that they are not dictating, they are not capturing political power and shaping public policies. That would be my view.
Thank you. That's a great question, a great response. One last question, 1 o'clock, one more to go.
Hi, thank you so much. I really appreciate how you have been able to intersect the stories of individual human rights and structural governance and financing. I think that's an important through line that we don't talk enough about. You've referred to this moment as being particularly precarious with the rupture of multilateralism, but also with efforts of moving towards national health sovereignty, like the Accra Reset and such. I want to ask you how you think we can move more meaningfully towards solidarity and localization in the geopolitical system at this current moment.
There is huge geopolitical tension now. The UN is not able to achieve consensus on any issue. Member states are unable to agree. To break out of that impasse, rules must change. The reason that the impasse is there is that the UN reflects a reality of 80 years ago, the end of the Second World War, and other countries have emerged and they are seeing that power is not shared equally. So we have to break out of that by reforming the rules of how we work together. That includes the rules for peace and security, but also the rules for development. And for development, there are many ideas out there. First of all, about reforming the international financial institutions, those that were created to end poverty and to cushion countries from economic shocks, to be the lenders of last resort. Those must change so that they are equitable. And that will come if the governance is more inclusive. I remember one time when it was time for change of leadership at the World Bank. And there were two leading contenders. One was a Korean American public health official. Remember him? Jim Kim.
Jim Kim.
And he was seen as is going to be progressive. He's coming from a public health background. He's going to head the World Bank and make it more caring, its policies more inclusive. And then the other candidate was an African woman, Ngozi, my sister. We Africa, we are all sisters and brothers. My sister Ngozi, who was a career staff of the World Bank, an economist, brilliant, had been Minister of Finance in her country, but essentially a conservative person on economic issues. So the debate was, who should lead the bank? I was more for Ngozi, even though I don't agree with her on economic policy. I am more, you've heard my views. I'm a socialist. She's not. But I supported her because I wanted her election would change the rules of the bank, the governance rules. For the first time, a person from the South would head the bank, because the unwritten rule is that it must always be an American or from Europe, right? So I wanted to change the rules, to change, for her to force a change of the rules, but I didn't really like her economic stance. The one whose stance I liked was an American citizen, and the governance would not change. I was more for a governance change than a possible policy shift. So I've used this story and taken long to explain that rules must change, both in terms of the development cooperation rules and as well as on the side of peace and security. So the focus on reforms is very, very important today. But sadly, what I'm seeing now in the UN, we are only doing the change which is possible, which is doing efficiency gains, driven by the cuts by an American administration. We are not doing the structural changes that will change and create more inclusiveness, more transparency, and more equity in the system.
Thank you, Winnie. I think the time is up, and I just want to close by saying it is sometimes said that courage is the most essential virtue because it allows for all the other virtues to come forward. And I think in this woman here, you're seeing in a very quiet way an enormous amount of courage to speak truth to power. And we are absolutely thrilled to have you here, hosting you at Penn. And you are clearly a role model for all of us. So let's thank Winnie one more time.